Principles of day case surgeries. So I outline day case surgery is defined as scheduled surgical procedures provided to patients who do not require hospital stay overnight. It entails a concept of care by which suitable patients are admitted, treated, and discharged on the same day. It can be diagnostic or therapeutic procedures. It can be done under local, regional, or general anesthesia. It carries minimal risk of post-operative complications and require a period of observation in the hospital. So it is known by different names. It can be called day case surgery. It can equally be called day care surgery, ambulatory surgery, or 23-hour surgery. Day case surgery is one of the practices that shows how surgery has evolved and improved over time, and is a continuously evolving field that aims to improve patient outcomes, shorten hospital stay, and reduce economic burden. It can actually be an annex in a main standard hospital with its own theater, or it can be freestanding units. So NICO operated on 7,392 children as day cases at Royal Hospital for sick children. This development in surgical and anesthetic techniques with emphasis on simpler procedures with fewer complications was what he proved with this procedure. The hospital-based day cases unit was started in the US in 1960s. Walter Reed first freestanding day case unit was established and surgeries were carried out. In 1970s, the UK equally followed suit, and the reports such as those of Royal College of Surgeons of England of 1985 and 1992 followed afterwards. The Audit Commission in 1990 and 2001 focused attention on the benefits of day surgery and set up standard and guidelines for the operation. The ideal design of a day case surgery unit is as follows. 1. It should be a self-contained dedicated unit or area within the main hospital environment. Facilities that are needed are: 1. There will be a reception cum waiting area. There will be operating theater and anesthetist room. First stage recovery area is required. There should be more of trolley than beds. It should be adjacent or close to the car park. It should have standard opening and closing hours. So admission process should be quick. Also, management and staffing of this particular daycare unit should have enough staff, standard staff, and the pattern with the main hospital theater. Clinical consultants should lead the team. Surgeons or anesthetists are required. There should be support services, lab and radiological services, or efficient collaboration with hospital main laboratory. There should be high quality, age appropriate advice leaflets in the place, and people can have access to it. And there should be virtual ward system, meaning that after the procedure, patients should be followed up virtually with calls, even video calls are equally needed. Caregivers should be planted in patients' homes, and there should be appropriate documentation. So the procedures in day case surgeries are as follows. It could be diagnostic or therapeutic. Diagnostic procedures that can be done in day case surgeries are endoscopic procedures like esophageal, gastroduodenoscopies, colonoscopy, sigmoidoscopy, endoscopy, retrograde cholangiopancreatography, bronchoscopy, bidacinoscopy. Then tissue biopsies such as fine needle aspiration cytology, through cut biopsies. There are radiological procedures like intervention cholangiography, T-tube cholangiography, laparoscopic procedures like inspection and tissue biopsies in liver pathologies, lymphomas, and the rest are the things done as day case procedures in a diagnostic manner. Others are endoscopic procedures like excision of polyps, injection of sclerotherapy of bleeding bleeding esophageal varices, insertion of stents, extraction of gallstones during ERCP, ligation therapies for hemorrhoids. Then laparoscopic procedures like appendectomy can be done. We can have a laparoscopic appendectomy, should be a day case surgery. Then laparoscopic cholecystectomy should be a day case surgery, and the rest. So other therapeutic procedures can equally be open, like heniographies in some centers are done as day cases if there are no other comorbidities. Hydroselectomies, varicocelectomies, removal of lumps, biopsies, radiological like ultrasound guided drainage of abscesses, then ultrasound guided sclerotherapies, all are done as day case surgeries. Examples of day case surgeries done in hospitals, department by department. A few of them are listed here. General surgery units will have cases endoscopies, then biopsies as well. In urology, we have the ureteroscopies, cystoscopies, ureteroscopies, prostate biopsy, digest stenting, stent insertion, stent removal, plastible circumcision, varicocelectomy, hydroselectomy, even bilateral total orchidectomies. Then in pediatric surgical units, a few of them, plastible circumcision, sleeve circumcision, and the rest are done by this unit. Plastic and reconstructive unit, incision and drainage. You have the ZX procedure, DTSU. They do procedures like ultrasound guided pericardial sentences. Trauma, they do procedures like tendon repairs, suturing of lacerations. Obstetrics and gynecology department, we have procedures like hysteroscopies, endometrial biopsies, polypectomies, and the rest are all done as day care cases. Then the criteria for patient selection, these are based on the following. It can be social factors are there, physical and medical factors are there, then surgical factors are there. Patient is assumed to have met all this for us to select them for this procedure. So under social factors, we have our own setting. It is important that patients should not come to hospital alone. It is equally required distance from the hospital should be minimal, especially more in time than even the distance, because we all know that some places are close to the hospital, but as a result of bad road or even a traffic jam that you normally have in some times of the day, it takes them longer to be in the hospital. Therefore, this must be put into consideration before selecting a patient for the day case surgeries. Other things that you need are the terrain where the person is living. Is it safe to come out at night or not? Then the transport vehicles in lieu of ambulances. If there are no ambulances, at least the person must have a transport car of his own, or maybe have a neighbor or so that is by the person's side to bring the person to hospital when required. We know that in some places in the Western world, that once you have issues, you call ambulance, they come to your house and pick you to the hospital. Even the ambulance personnel will tell you what to be doing while waiting for them to come and pick you up. But in our own setting, we are still developing, and we believe with time we should be able to reach there. But for the meantime, the person that we are carrying out this procedure for should have access to transportation. So availability of toll-free telephone services in case of emergencies. Many times we call a particular place, you start hearing grammar and all rest of them. It takes time before they even answer you. When you look at it, they are deducting your money. So in cases like this, for one to be socially fit for this procedure, there must be toll-free telephone services 24/7. Then home environment, there should be ease of movement on wheelchair and use of commode if need be. There should be availability of relatives, skilled or unskilled anyways, for initial 25 hours of care, skilled or unskilled depending on the procedure the patient underwent. We equally have the physical and medical factors that patient must meet for the patient to be part of day case surgeries. One, the age must be less than 70. The patient must meet the American Society of Anesthesiology grade 1 or 2. Body mass index must be less than 30. The patient, if diabetic, must have good sugar control. The hypertensive must have good control of the hypertension. Chronic liver disease patients will not have derangement in their clotting profile. Renal heart failure, we won't book such cases for day care surgeries. People that have obstructive sleep apnea, we must avoid some analgesic while taking them for the surgery. Then surgical factors that patient must meet are as follows. Short duration of surgery. Surgeries are advised to be between 1 and maximum 2 hours for it to be qualified for day care surgeries. Procedures needing longer recovery should be scheduled early in the day and local anesthetic cases should come later. Then absorbable sutures and improve wound closure to reduce need for stitch removal must be met. Patient must not require blood transfusion, such that post-operative instrumentation, monitoring or medical input or specialized nursing are not required in cases of day case surgery. So patient that after the procedure you need to catheterize, you need to pass NG tube or put drains, they are not booked for day case surgeries. So other surgical factors needed are patient must not require major post-operative analgesia. Access to inpatient beds should be available. Some cases of day case surgery may have need to be converted for admission. So in such a center, there must be a place for admission if need be. Surgery must be by an experienced surgeon, because this is something you want to do, a procedure you want to do and send the patient home. So as such, experienced surgeon should be the one to take up the procedure. Procedure should not have serious post-op complications such as hemorrhage or cardiovascular instability. Procedure should not preclude early return to oral feeds. You would want your patient to eat as soon as possible after the surgery. Early independent mobilization should be possible. So any procedure that require a patient to be on bed for more than a few hours should not be booked as day case procedures. Now, contraindications to day case surgeries are, you can have the absolute and relative. One is if surgery is required before the patient's condition is optimized, kindly convert such a procedure for elective or emergency in the main theater. Then elderly patients more than 70 years, we should not book such a patient for day case procedures. So relative contraindications are a patient that is obese, or patient that have obstructive sleep apnea. You must avoid opioids, as we said before. Then unstable chronic diseases, you should not book such a patient for day case procedures. Then principles of day case procedures, we have the preoperative, intraoperative and post-operative. In the preoperative, what is required is, first of all, this is done in the pre-op clinic. You must see your patient in the clinic and do a good selection based on the factors we listed earlier. Aim is to make diagnosis and assess fitness for day case surgery and anesthesia. So in preoperative procedures, as we said earlier, it is done in the clinic. Our aim is to make diagnosis and assess fitness for day case surgery and anesthesia. We take detailed history, examine patient and investigate patient. Then in history taking, it has to be detailed. Being a day case doesn't mean that you take anyhow history. No, it has to be a detailed history taking. Your history of presenting complaints must be detailed. Medical and surgical history must be detailed. You rule out every complication, especially having heart disease, to which extent, pulmonary disease, bleeding tendencies, hemoglobinopathies, any of them, if there are yellowness of the eye, you go further for investigation for your clotting profile and the rest. So there must be detailed history taking in order to allow us to do a good patient selection. Then other pre-op assessments include personal anesthetic problems. Has the patient had surgery before? Had he ever used anesthesia? Did he react to it in any way? Allergy or sensitivity, drugs, history, examination, and also assessments for complications, if any, is carried out in pre-op assessment of these patients. So we have to further investigate patients, one, to confirm our diagnosis, to rule out differentials, to know the extent of the disease, and work up patient for surgery. In pre-op workup, we have to do our laboratory workup, looking at hemoglobin, urinalysis, chest X-ray, ECG for patients more than 40 years, electrolytes where indicated. All this needs to be carried out. So pre-op assessment, if patient meets all the required, we counsel patient and give the patient consent. Then intraoperative anesthetic consideration must be put into place. You have to use the best, anyway, preferred one is local anesthesia. In cases of bilateral total occlusidotomy is used. Then regional anesthesia like epidural or spinal is equally used, but the risk of urinary retention is here. Then pre-medications where indicated, you make them available and use them intra-op. General anesthesia can be used in cases of total intravenous anesthesia. It can be used. Propofol is actually safe in this area. Wound closure, you use absorbable sutures, as we said earlier, so that you prevent coming back for stitch removal. Then post-operative care, you have the post-anesthesia care, which is done in the PACU unit where the patient is monitored. You have to look at pain management, antiemetic where need be, then antibiotics where we have need for it as well. You monitor vital signs, evaluate patient mental status. Then patient is to be discharged when the vitals are stable, the blood pressure, can patient ablate, what the patient mental status, pain and post-operative nausea and vomiting subsided or taking control by the analgesic we give. The surgical bleeding side we check and our dressing is neat and fine. Fluid, whether the patient can take fluid and equally can urinate without any problem. Patient should have an adult before we do to take the patient home in the course of our discharge. So discharge instructions for regional anesthesia, motor and sensory functions, you have to tell the patient that the motor and sensory functions will return first, while the sympathetic nerve function will return later. So that's why people that had spinal anesthesia might come back down with urinary retention. Then before ablation, you have to check to know whether the S5, S4, S5 sensations are there, the ability to have a plantar reflex and the foot. If we use our spinal anesthesia, we have to check before we discharge a patient and equally give the patient instructions on that. Advantages of day care surgeries are, for the patient, it actually has minimal disruption of patient's lifestyle, early return to work, then reduction in waiting time, because if you have elective, you can take weeks or months, but if we book the ones we can do a day care surgeries, it will be easier for the patient at the same time to be attended to early enough. It equally lowers the cost of hospitalization. It reduces the risk of hospital-acquired infection, the nosocomial infections as well. Then it has reduced psychological and emotional impacts on the patients. In children at home, it reduces what? Behavioral, sleep pattern and disturbances. Disruption of family life are equally what? Avoided by this procedure. Then advantages continued to the staff, more attractive to the staff because of reduction in shifts. Like it reduces people that come for night shifts, because we have almost of our cases as day cases and I can go the same day or within 24 hours. Then the lists have faster turnover and run more efficiently. Patients are more mobile and less dependent on the staff and other clinic on the staff in the hospital. Then challenges of day case surgery as follows. Not all cases can be recruited for day case surgery. As we mentioned earlier, the factors we must consider before recruiting patients for day case surgeries. Social infrastructures needed for increased spectrum of case mix. There may be no funds available for that. Full involvement of consultant surgeons, reducing their own work where they're supposed to be. At the same time, we'll have limited number of doctors as another medical staff as we know today in Nigeria. So dividing them into different fields will reduce the efficiency and efficacy of work done in other areas. The need for a responsible companion to oversee the daycare patients at home for the first 24 to 48 hours is a burden to the family. Burden of care passed to the family members too. They may not be happy with that. And good organization and management are needed for us to have a comfortable one. So future trend is that healthcare guidelines have advised daycare surgeries are norm for elective surgeries, and target is that 75% of elective surgery should be daycare. And in 2016, recommendation for clinicians in the Choose Wisely series by the Academy of Royal Colleges is that daycare surgery that default most surgical procedures. Then so far after doing the work, you need to this template are going to how many cases do we book, how many out, how many pre-op cancellation do we have in this, addition after the case surgery as a result of failure of the patient to recover and go home, and the anesthesia guilty, any complication from anesthesia, the recovery, discharge time, and all should be, you should audit your work and see how far and how good you have done so far, and then plan yourself wisely. So in conclusion, daycare surgery is one of the important concepts in the current surgical practices. It is beneficial to both the patients and the healthcare providers. Success is dependent on adequate patient counseling and preparation. Both medical and social factors are considered in suitability. Multidisciplinary approach to establish protocols for patients' inclusion and exclusion criteria is best agreed locally. So there are ranges of procedures, as we listed earlier, that will benefit from this day case surgeries. Thank you.
In what situation would a day case need admission?
Conditions that day case procedures might admission. Once we are doing a surgical procedure, and part of our selection criteria is that we expect such a procedure not to cause what? Hemorrhage. But you might have inadvertent what? Trauma to the what? To the blood vessels, and that can lead to bleeding. And if such a patient is bleeding and you try to stop it, the bleeding still persisted. So persistent bleeding after surgery, you wouldn't allow such patient to go home. You have to admit the patient, do other things, and equally monitor the patient. Some other conditions that you expected ordinary or simple analgesia to take care of. At the end of your procedure, patient still have what? Intractable pain. You need to go further and see. Then some procedure that maybe you thought will be a day case, but when you go in, you can't do what? You were not able to end where you expected to end. You have to extend the procedure. The patient may equally need to be in the hospital for a while. What if you now give spinal anesthesia? The spinal anesthesia you gave now turned out to be total anesthesia.
Remember the day case surgery, we talk about criteria. The criteria for day case surgery has to do with selecting appropriate procedures. Then you have to select the patient properly. You understand? So yes, we have conversion, but bleeding is not something that is a common complication. Yes, it can occur and it can result in you monitoring when you feel the blood loss is more unexpected. What are the common things that makes you keep patients that they came for surgery and you expect them to go home?
You can have a total spinal anesthesia, which can lead to paralysis of the muscles.
Remember your criteria. It's safe practice. Skilled surgeons, skilled anesthetists with adequate supervision. Have you ever seen a total spinal?
I haven't.
Anesthesia, you could talk about probably there was some complication. Probably the patient reacted to the anesthetic drug. And for your regional anesthesia, for spinal, at times they could have urinary retention during recovery. And for day case surgery is not really what we like to use. When you are choosing the anesthesia, patient should be able to ambulate on time after surgery.
Consistently using the you advise on the use of the third person pronoun. That is always better. In your presentation, it was you. In all your answering your questions, you are saying you. Consistently using indefinite words like and so on, etc. Patients will be discharged a few hours later. No, there are timelines to that. There's timeline to day case surgery. After which, if patient is still in admission beyond that, you convert. There are timelines to recovery. Importance of the ASA classification.
The ASA classification, which is known as the American Society of Anesthesiology classification, which is used in assessing the patient that will be fit for different types of surgery. For day case surgery, we said ASA 1 and ASA 2. So in ASA 1 is a person in good health, a person that doesn't smoke tobacco products. In ASA 2, we have people that have mild but well-managed, treated conditions.
You're saying that anybody who when you see a patient that's smoking, then the patient falls off as a one.
Excessive smoking.
So what will excessive smoking do?
To cause lung pathology.
So a patient with any form of lung pathology, irrespective of the etiology, and yet they are very fit, so to speak. They don't have any. You do a chest X-ray, you see clear lung fields. You check blood pressure. Blood pressure is good. You check blood sugar. Blood sugar is good. Will you say because the patient the patient is solid smoker, no longer? Do you understand? So you have to be careful the things you say. The only
Yes,
difference
sir.
that those smokers, when you do an autopsy, you see that they have black lungs. It doesn't mean that lung is not functioning. It's just the discoloration. That smoking habit will lead the patient to tip an unfit status when there's a pathology in the organs.
Okay, sir.
All right, thank
Okay,
you.
thank you, sir.
Go with your
So,
discussion.
okay, sir. Thank you. So, ASA 1 is people that are fit, no pathology. ASA 2 are those that have mild but well managed conditions. Like someone that is pregnant has had maybe mild lung condition before, but is now fine. Someone that has asthma but not symptomatic and well treated falls into ASA 2. ASA 3, looking at a serious condition that has impact on person's overall health. Like person who has a body mass index greater than 40, so the person belongs to ASA 3. And ASA 4 is severe health challenge that is life-threatening. A person with a severe infection like sepsis is on dialysis regularly, and these people belong to ASA 4. Then ASA 5, we are looking at a life-threatening condition that needs immediate surgery to even increase the person's chances of living. They added ASA 6 is this person who is an organ donor, is not actually popular in our area. Someone that has diabetes, this person who is an organ donor, so it belongs to ASA 6.
Also, ASA 3 can be included at
Bless
times.
you.
Okay, so it's ASA 1 to 3. So because patients might have a systemic disease, but it's not incapacitating. So the patient might still be able to benefit from day case surgery. Maybe you
Okay,
use
sir.
local anesthesia.
5 is moribund patient.
American Society of Anesthesiology grading system for patients going in for under anesthesia. It's graded from 1 to 6. E aspect, the fact that if it's an emergency, there's a prefix or B, there's an addition of an E that must be added. What is being assessed is the patient's systemic disease. If the patient has a systemic disease. So ASA 1, the patient is fit with no systemic disease. ASA 2, the patient has a mild systemic disease, but it's not incapacitating. It's not a constant threat to life. Then for 3, the patient has a severe one, but it's not a threat to life. It's not incapacitating. For 4, it is incapacitating and is a constant threat to life. For 5, the patient is moribund and is expected. Moribund means the patient may die with or without intervention within the next 24 hours. And then for 6, the patient is brain dead. And then if it's E, the patient there's an emergency attached. So the patient can be ASA 1E, ASA 3E, as the case may be. The criteria for discharge. When will you say a patient is fit to be discharged? And what instructions will you give the patient after the patient has been discharged from surgery? So there's even a criteria. There's a post-anesthesia criteria. You can look it up, but there are some common things. The patient should be, you are looking at the level of consciousness. The patient should be awake, alert, should be oriented in time, place, and patient. The patient must have normal vital signs. Must be no evidence of bleeding. Also, there should be minimal or no presence of post-anesthesia, nausea, or vomiting. Patient should be stable. Patient should be able to walk. Patient should be able to ambulate. So those are some things you look at. So if the patient doesn't fulfill that criteria, you know that, okay, the patient is not going to be discharged and may need to be admitted. So if you had talked about it, that question would not have come up. For your future trends, you could have mentioned, this more of a comment, you could have mentioned, the ERAS, that's the enhanced recovery after surgery. If you've heard anything, you can just give us a small talk about it if you've heard it. And then my other question was you said that propofol is the ideal anesthesia for day case surgery, for general anesthesia. The question is why?
247 she's using is not right in presentation. Was emphasizing obesity being excluded from day case. He also went further to put obese patients at relative contraindication. Meanwhile, as of today, obesity is more like one indication for day case surgery, a very sound indication, general surgery wise, and even orthopedic, arthroplasty, and other. I don't know whether you should be able to throw light on this. What is the grade? What is the limit for an obese patient? You gave 30, but I think that is wrong. BMI of 30.
In the course of the discussion, we say that day case units can be part of the hospital or standalone. Although in most parts of our country, we are still developing to that.
If obesity is a contraindication, do you even know why obesity should be treated as a day case as much as possible? If you have a lump, maybe some breast lump to take out in an obese patient. If you have a lipoma to take out in an obese patient, you mean you won't take out that lipoma? You will admit the obese patient so that the obese patient will throw embolus on you, develop a DVT. A morbidly obese patient, if a patient is more than 40, you don't want to incapacitate that patient in any form and say go home. So you may have to observe the patient. But even when you're observing the patient, you must also observe all those ambulatory precautions.
Some talk about probably the patient should live within a 60 minutes drive from the hospital. That's enhanced recovery after surgery, which is the current trend in surgical practice, which entails not operative fasting. She gives at least a glucose drink at least 2 hours before surgery. Commence oral intake early after surgery, even for gastrointestinal surgery. So even cases that normally patients will stay on admission for, even appendectomy, they are thinking about doing it same day and patients going home. So for pediatric patients, I is propofol preferred. It's preferred because it brings about rapid induction. Then during recovery, anesthetic complications of nausea and vomiting is less. Then recovery is also smooth, is why it's preferred. But they also consider the use of even gases. You understand? You didn't talk about the anesthetic gases that can be used, which they use also in children. So they prefer sevoflurane, you understand, if it's available.
Do you do day case surgeries in OBS and GYN in O&G? Which ones do you do?
Hysteroscopies, endometrial biopsies, the polypectomies, cervical polypectomies most times. Diagnostic laparoscopy.
Laparoscopic Fallops ring.